All right, so next up we have Dr. Sudheer Polisetty, who is a board-certified internist in Las Vegas, Nevada. He is affiliated with the University Medical Center St. Rose Dominican Hospital's San Martin campus and Veterans Affairs Southern Nevada healthcare system. He will be presenting on the alternatives for anti-thrombotics in patients with bleed risk and heparin-induced thrombocytopenia. We can start the presentation now.
Hi, good morning, everyone, and good evening to all my friends and colleagues in India. So my presentation is pretty straightforward, and thanks to Dr. Shobin for giving the extensive presentation on the anti-thrombotic options we have. So my topic is alternatives for anticoagulation is basically no anticoagulation. So the question of not using anticoagulation arises in three major scenarios. One, when there is absolute contraindication for anticoagulation, which is a recent intracranial bleed or a GI bleed that could not be stopped, and coagulopathies, severe thrombocytopenias, and cerebral or cerebrospinal tumors that are high risk to bleed. The second indication for not anticoagulation is someone developing a bleed while on anticoagulants. And the third one is failure to anticoagulation and like recurrence of DVTs and PEs while on anticoagulation. And there are some extended indications when there is a still clot burden and there is a iliocaval DVT, massive PE with low pulmonary reserves, like patients with severe cor pulmonale or severe pulmonary hypertension, and poor patient compliance, severe liver disease, frequent falls. These are some extended indications where we cannot anticoagulate for all these reasons. So what are the options we have? These are the non-contemporary options. We use IVC filters, and in some places they use thrombolysis. So going for the inferior vena cava filters, these are metal meshes made of stainless steel or nitinol. These are placed under fluoroscopic guidance in the inferior vena cava and sometimes rarely in superior vena cava. The purpose of this is to catch any big clot that might be going into the pulmonary arteries, causing a saddle emboli that could be life-threatening. So there is a trial in 2011, the PRECIP trial, which was studying the permanent filters. And the study said use of inferior vena cava decreased the incidence of life-threatening pulmonary emboli, but they increased the risk of having more DVTs. So it's give or take, and it should be decided on patient-to-patient basis after proper discussion with the patient about the use of the inferior vena cava filters and its complications. Nowadays, we are using something called retrievable filters, which are in place for 3 to 6 months, and we take it out. So that's about inferior vena cava filters. And the complications of these filters, as you can see, there is a chance of filters embolizing to the pulmonary arteries and the thrombosis of the filter itself, and the long-term complication is inferior vena cava stenosis. Going to the next topic, heparin-induced thrombocytopenia or heparin-induced thrombocytopenia thrombosis complex. So basically, it is one of the life-threatening complications when we are using heparin, unfractionated or low molecular weight heparin. It has been reported up to 5% in patients who use heparin, and it happens regardless of the duration of exposure, the quantity, the route of administration. The way heparin-induced thrombocytopenia develops is you develop autoantibodies against platelet factor 4 and heparin complex. So when these antibodies develop, they activate the platelets, causing more thrombosis, thrombocytopenia, and complications related to the thrombosis. This could be arterial as well as venous thrombosis. And untreated HIT has a high risk of mortality up to 20%. Going to the next slide, there are two types of HIT, type 1 and type 2. Type 1 is more common, but it is less serious. Once you stop the heparin, the platelet count recovers. But type 2 is less common, but more serious, more risk of having thrombosis events. And This is the one I'm going to touch today. Going to the next slide. So diagnosis is made basically seeing at the platelet count a drastic drop of 50% from the baseline or 30% to below 100,000. The platelet count can go up to less than 60,000. And it should start like 5 to 10 days after starting the heparin. And you should see thrombotic events or skin necrosis while on heparin. And we need to rule out other causes like ITP, DIC, or drug-induced thrombocytopenia. And the platelet count should recover once the heparin is discontinued, and there should be HIT antibodies to diagnose this condition. The other findings we see is, as I said, like drastic drop in the platelet count, thrombosis, skin necrosis, and we can see anaphylactic reactions in some people. So we do a couple of blood tests to detect HID, which is immunoassay, which is ELISA, and the other one is a functional assay that serotonin release and heparin induced platelet activation immunoassays. Going to the next slide. So as you can see, once you see the platelet count dropping down, we do a parameter analysis to see the possibility, like the pretest possibility of diagnosing a HIT. So we go through this 4T score, which basically covers the level of thrombocytopenia, the timing of onset of the HIT findings, and the thrombosis events and other causes. So 4 to 5 intermediate risk, more than 5, 6 and above is high risk. So if you go to the next slide, this is how, once we diagnose someone with possible HIT, we send a HIT antibody test, and then basing on the 4 T's probability, we classify low probability and intermediate to high probability. So once we get the ELISA, the optical density reading, if it is 0.6 to 1, we consider as possible HIT level, and then we go with the classification. If it is less than 0.6, we rule out HIT for the ELISA. It's 0.6 to less than 2, we check the functional assay, which is the SRA and HIPA. And basing on those assays, if the functional assay is positive, we classify them as positive HIT and management basing on that. And if the ELISA, initial ELISA, the optical density value is more than 2, we consider it as positive HIT and we treat them as HIT. So once you have a HIT, we have to immediately stop the heparin or low molecular weight heparin and start them on non-heparin based anticoagulation. If it's HIT positive and there is thrombosis, the treatment can last up to 3 months. If HIT antibody positive but no thrombosis, the treatment should be up to 4 weeks. And the treatment options we have for HIT, we have the direct thrombin inhibitors. Parenteral, we use agratroban or bivalirudin, and oral, we use dabigatran. And the other options we have is factor 10A inhibitors. Parenteral, the subcutaneous form of Parinox. The oral, we can use the apixaban, edoxaban, or rivaroxaban. Vitamin K should not be started while patient is on HIT. Once they are stabilized on a non-heparin based anticoagulant, then we can start it down the line. So that's about it. Thank you.
Thanks so much, Dr. Sudheer Polisetty. He has saved a lot of lives in Las Vegas region, and it's great honor and pleasure to have you in this delegate panel. And keep up the good work. We need your help in future webinars.
Sure, sir. I'll be there. I'm at work now, so I'll take a break. Thank you.
Thank you so much.
Have a good day, everyone.
So there is